Do this? All right. Well, good morning. Welcome to the first meeting of the year of the Joint Committee on Fair Practices and State Personnel Oversight. I'm Delegate Laura Charkoudian. I'm the House Chair. We're joined this morning by construction, among other things. So I appreciate everyone's patience with that. We have some members coming. My Senate Chair, Katie Fry-Hester, is on her way, sends her apologies, and will be here shortly. But we'll start on time because we have a lot to cover, and we are live streamed. I know a lot of people are interested in the issues that we're discussing, and so I'll just make a couple of comments by way of opening, and then we'll ask the Department of Health to get started. So thank you all for being here, and thank you for your interest. This is the first committee of this year, and it's the first committee that I have been the chair of. We do have Senator Lamb, who's previously been the chair, and look forward to your comments today as well. The issues that we're covering today within the Department of Health related to capacity issues in nursing home inspections, issues at Clifton T. Perkins Hospital, and in general staffing and vacancies in some of the critical areas, in particular the 24/7 facilities are issues that have been discussed and reviewed by this committee over a couple of years, and we're continuing that process. They obviously relate to issues that are of significant concern for our the general public, for people who are being treated in the hospitals, and for the staff as well, and so and people who are being cared for in the nursing homes. So we appreciate the department's focus on these issues. We appreciate you joining us this morning. And I think what we'll do, since it's a relatively small set of us, is we'll ask you to go through the first set of slides. We'll stop after the first section, take questions and answers, and then the second set and the third set. So we have those, our agenda for folks who are following. Oh, you can see the agenda. Anyone, wherever you're following along from. And so we'll start with any opening remarks, Madam Secretary, that you want to share, and then we'll start on the presentation.
So, wonderful. Well, thank you again for having us here, and good morning to all of you. And again, thank you for inviting us to be here today to talk about some of the progress we have made at the Maryland Department of Health. As you mentioned, Chair Charkoudian, each of the topics before the committee today are key to our work, and they have been priorities for my team since I started as secretary. So I'll be turning over, as you mentioned, to my colleagues for the presentations, but it would be good if I can just take a moment to highlight some of their work. So Dr. Meg Sullivan is our new Deputy Secretary for Public Health Services, and our Executive Director, Tia Witherspoon, is here as well. And they'll report that since our department was last before this committee, we have made significant progress on nursing home inspection backlog. And we've reduced the number of surveys in the backlog by 83%. We will then move to talking about Perkins. We have brought on a new Chief Executive Officer there, Dr. Aaliyah Jones, who has successfully led the facility through reaccreditation. And I've also brought on a new director for the overall health system, Dr. Anita Everett, who is looking holistically at our hospitals to ensure appropriate care for our patients. And then third, we'll turn to, a conversation about the hiring freeze. We continue to prioritize filling positions, and we have many positions that are exempt from the hiring freeze as well, including those at our hospitals. So again, we appreciate all of the work that you all do, and we look forward to continuing to work with you, and are happy to be able to give this update as we continue to work together on these really important issues. So with that, I will turn it over to Dr. Sullivan so she can begin the presentation on nursing home inspection. So thank you.
Great, thank you so much, and good morning, everyone, and thank you for the opportunity to present today. I'm just going to spend a few moments just providing a brief update on the progress of our nursing home inspections. So we go to the next slide. Just wanted to start with a brief reminder and overview of the core functions of the Office of Healthcare Quality, or OHCQ, which is the agency within the Maryland Department of Health that determines compliance with state licensure and or federal certification requirements in 47 types of providers and programs. And again, just as a brief reminder, with state licensure, the OHCQ issues licenses that authorize the applicant to operate a certain type of business in the state, whereas in federal certification, it works closely with the Center for Medicare and Medicaid Services, or CMS, to allow a facility to participate in and seek reimbursement from Medicare and Medicaid for services provided. Next slide. This slide just provides a brief overview of the number of providers that OHCQ oversees. And what you can see here is that as of July 1st, 2025, we oversaw 23,095 providers in 47 different industries. And as the graph illustrates, this number has been increasing. In fact, there has been a 21% growth rate in the total number of licensed providers over the past over the past 5 years, and a 3% increase specifically from FY24 to FY25, and we anticipate this number may continue to further increase. Next slide. I did just want to spend a little bit of time providing an overview of our current staffing of surveyors by program. These next couple of slides highlight a few of our programs, and specifically for the purposes of this presentation, I'll focus on our long-term care or nursing homes, where we currently have 61 health facility surveyor nurses, which includes 12 positions that we added by the end of FY25. Next slide. And as you can see, and what I'll talk about in a little more detail during the presentation, is we have been focused on increasing the number of staffing to meet the needs from what I just had talked about. And again, specific to nursing homes, you can see the growth from FY23 to FY25, going from 41 to 49 health facility surveyor nurses, and then again talked about adding 12 more this fiscal year. Next slide. And this slide just highlights, among other programs as well, we've been focused on increasing that growth as well. Next slide. So I want to spend a little bit of time talking about where we are with the annual inspection backlog. And first and foremost, just to say unequivocally, as Secretary Seshamani already said, addressing the nursing home backlog, inspection backlog has been and will continue to be a top priority for OHCQ and for the department. As you can see here, just to further delve into the progress that we have made, in December 2023, we had a backlog of 172 annual full surveys. In December 2024, that was down to 127. And we currently, as of this month, have 26 annual full surveys, which represents actually more than an 83% reduction in the backlog since December of 2023. Next slide. So I want to spend a little bit of time talking about how we address this backlog, and really focused on 4 parts of a strategy. The first 2 related to staffing, looking at securing staffing for both merit-based surveyors as well as contracted surveyors, which I'll talk about in a little more detail. We also focused on improving our efficiency and quality of our training, as well as finding overall efficiencies in our operations and survey process to allow us to be more efficient in what we are doing. Next slide. Specifically with staffing, we were able to secure staffing for contracted certified nurse surveyors that allowed OHCQ time and flexibility to train and transition merit staff to full independence. And as you may be aware, when we bring on new staff, it does take a significant amount of time to train them until they are able to conduct surveyors. And so again, these contracted certified nurse surveyors really allowed us to have the time to do that. And then, as we are simultaneously part of our strategy, securing the staffing for the merit-based certified nurse surveyors, which, as I highlighted in previous slides as well, you can see we have hired 33 new long-term care surveyors since July 1st, 2023, and you can see the breakdown on that side. The other 2 things that we focused on were contractual PIN conversions, so allowing us to convert 10 OHCQ contractual positions to merit, which again helps with retention, and worked to increase the state salaries for our nurse surveyors by 2 grades, which has positively impacted, again, not only recruitment, but retention as well, and has put us in a much more stable place for staffing. Next slide. The other thing that we focused on was first looking at our training and able to decrease our surveyor training time from 12 months to 7 months by, again, focusing on those areas that were most critical, reducing some of those inefficiencies that were not necessary for the training, and focused on getting people into the field to allow their training to continue there. We also have been focusing on efficiencies in survey completion while really ensuring that we are maintaining quality and compliance standards. And if you go to the next slide, these are just some examples of those efficiencies. For example, focused on technology and enhancing the use of technology for field-based employees, looking at leveraging our data from CMS alongside internal data analytic tools to be able to monitor our backlogs and operationalize or enhance our operational efficiency. And then streamline our survey scheduling, for example, implementing geographic-based scheduling to assign surveys near surveyors' homes to really minimize some of that travel time or time not spent doing surveys, again, to increase the number completed efficiently. Next slide. So in terms of where we are, as I said previously, we currently have 26 surveys remaining in the backlog, and we have been actively working towards full compliance with annual full surveys by December 2025. Unfortunately, I will report today that we have hit a bit of a hurdle with the federal shutdown, in that the current guidance we are receiving from CMS is advising us that we cannot conduct routine annual surveys. We still are allowed to go in. There are accepted activities that we can talk more about, but really relate to immediate jeopardy or non-IJ high complaints. But currently, routine annual surveys we cannot complete. We have been having many conversations with CMS. We have been talking with other states as well as national organizations to see if we can kind of push CMS and get any sort of exceptions to this guidance. But at this time, we are in a pause mode for our annual surveys. And we can talk a little bit more about that if there's questions. Next slide. Do just want to focus, I know we are here today focused on the numbers and where we are with the backlog, but I will say throughout all of it, we have been ensuring that we are not just completing the surveys, but that we have systems in place that really focus on quality assurance as well to make sure the surveys are not just done efficiently, but they are done with high quality. And this slide just represents a few things that we have been focused on. Already spoke a little bit about data-driven oversight. Been working very closely with a wide variety of stakeholders to incorporate their feedback, including from providers and internal review panels, to ensure our survey protocols are up to date and our regulatory expectations are clear. We've been really looking at quarterly audits of our completed surveys to identify any variations in citation pattern to really ensure consistency and promote uniform enforcement of both our COMAR and federal standards. Talked a little bit about training, but this training is ongoing and really focused on ensuring competency-based training and mentoring for both new and existing surveyors to maintain survey quality, and then really have an entire process focused on continued process improvement, again, around streamlining survey process, reducing errors, and improving our turnaround time for reports and revisits. And then, next slide, sorry. And then lastly, just want to say, I think, and again, we'll echo what Secretary Seshamani said, this is just an incredible priority for us to make sure that we are doing the surveys that we need to do and doing them well. But we are also very mindful of ongoing challenges moving forward that we are consistently talking about and addressing so that we can make sure we are able to continue this progress and don't find ourselves stepping backwards. So things that we are focused on include workforce retention and recruitment. We talked about the progress we've made, but we know that we still need to continue to sustain an adequate number of qualified nurse surveyors and administrative staff among statewide and national competition. Talked about managing provider growth and keeping pace with what is an anticipated further increase in licensed providers across the 47 industries. I think really making sure that we are balancing state and federal mandates, including navigating changing timelines and federal CMS expectations. Making sure that as we really focus on technology modernization and continue to expand digital tools, we are still really focused on ensuring data security and compatibility with CMS. And then finally, working closely with our providers to ensure provider compliance and readiness, including through addressing variability with provider types, such as the small rural providers. Next slide. I think we'll just end by echoing again, thank you for having the opportunity to talk about this. I think we have made incredible progress. We are trying to put systems in place to have that progress continue, and we look forward to answering any questions you may have.
Thank you. Senator Hester, did you want to say anything since you arrived?
No, we've got a tight timeline, so I appreciate y'all being here, and apologies for being a few minutes late. Traffic was bad.
Thanks. Are there questions? Senator Lamb.
Thank you, Co-Chair. This came up in a hearing, I guess this was like 2 weeks ago or so, and I certainly appreciate the update and just to be able to see the progress that's being made here. I guess my question is a follow-up to the prior line of questioning from earlier, which is, I think it's important for us to have a sense of how the backlog got to this point, so that, for us as legislators, we can pay attention to warning signs, we can provide more resources to the department, provide any support that's needed. It probably should never have gotten to this point. But, I think for us, being able to understand how we got here is important, not to, kind of relive the past, but at least to give us the proper warning signs for the future.
Yeah, and I think I can say, and I know, Senator Lamb, when you asked the question before, I told you, right, that Director Witherspoon and I had been having that conversation that morning, and even since you asked that question, we've been having further conversation, are working on getting some information back to you, and look forward to talking with you more about it.
Okay.
Thank you. Yeah, I'd be interested in those answers as well. And maybe as part of that, just as, can you back up a little bit and talk about what is involved in the inspections, what's involved in the survey, just so we sort of have a picture of that, and how much does that address some of the concerns that folks have about what is happening in some of the nursing homes, so sort of preemptively, like what does it look like? And then as part of that, sort of once we're very focused on the backlog, but once the backlog is, so what's happening with like regular inspections, right? So what's the time frame that they're supposed to be happening within? What should it be looking like if we weren't talking about the backlog? Can you kind of give that context?
Yeah, and I'm going to have Director Witherspoon go into the details. I think the two things I will say is first, I think really mindful of, again, sometimes looking on paper about numbers, but the actual surveys themselves, right? What does it look like? What is the quality? And I actually took the time, I think it was last week, to go on an inspection. This was of assisted living because of the shutdown, but to see how complicated it is, right? So, and this is about making sure it's not just about checking the box and getting it done, but that we have processes in place. And then I think second, to your point, every conversation that we've had has been about not just where are we with the backlog, but what are the surveys that are due this month, right? What are we looking to do so that we're, again, getting ahead of it rather than behind? But if you want to talk specifically about the actual surveys.
Thank you. So surveys there are various types of surveys. You have complaint surveys where maybe a resident or family member has called in and they have a specific issue that they would like us to look into. That's one type. You also have the full annual surveys, which is the ones that we are talking about here today. Those are very comprehensive. You're looking at everything from quality of care to food in the facility, staffing. You're looking at a full comprehensive look at their clinical services as well as operations. And then you have revisits as well that's in there. So if you have a facility where an issue has been identified and they put a plan in place, and there are times when we'll go back out to that facility and ensure that that plan that they put in place is working and is sustainable. So you have a mix of different types of visits for nursing homes that you could see at any moment in time. With the annual surveys, when we are on schedule and not working through a backlog, we would go out within 15 and 9 months. So CMS requirement is that every facility is surveyed within 15 and 9 months.
Sorry, 15 and 9 months?
Yeah, so essentially 16 months. That is your compliance window. So you have between 12 and 15.9 months, so 16 months.
15.9, sorry.
Yes.
Okay, I got you, sorry. So when we're looking at these numbers and when we're talking about a backlog of 36, that means there's 36 that haven't had their 16-month inspection since when?
So right now, we are doing buildings that are in 2023 and 2024 is where we are.
So there's there's 36 that had
26.
Sorry, the number on here I think is 36, but you're saying it's 26 now?
26,
Okay. So there's 26 that were last surveyed in 2023. Is that-
Yes, you have a few that were in 2023 and some that were surveyed in 2024 that we would be working to clear up.
So that's clear. And so then what does that mean for the other?
220?
Right, yes.
Yes.
What does that mean for those? They had one within the last 6 months?
Yes, so that
Is
means that
16
those
months?
other ones have had one. And so what we will do when operations resume normally, we would start to go back out within that, using their last survey date as the date when we would go back out. So from the last survey date, 15.9 months from there is when we would go back out, unless there is a complaint or an immediate jeopardy, and in that case, we'd be back in those buildings sooner.
And so that was my next question. What is so that's for the annuals that you were talking about. And then what's the volume of complaint-based inspections? And what is the timeline on those? And is there a backlog on those as well?
So we get about 4,000 complaints a month. Complaints are a little different because complaints are triaged. We have immediate jeopardy, we have non-IJ high, we have also a low and a medium in between there. We do have a backlog of complaints. Last year when we spoke to this committee, we were about at 5,938 complaints. Right now we are at 1,800 complaints, with most of those being medium and low. When we spoke last year, we had 346 high complaints. Right now, we're at 64 high complaints. So we've made significant progress on those, and the timeline for responding to each of those is a bit different. If it is immediate jeopardy situation, we're out there within 2 to 3 business days.
Okay. I think I have one more question. And so those complaints are based on, those are either from residents, family members, or staff?
Exactly.
Staff members as well?
Self-reported complaints is also facility reported complaints.
And then you may have said this, but I think you said by the end of this December, you expect to be, what's the timeline that you expect to be fully caught up on the backlogs?
Of complaints or of annual surveys?
Well, both.
So annual surveys, because we have the freeze from CMS, that timeline has been pushed out a bit. We're not sure when we will be able to resume those. We were expecting to have a completion date of this December 2025. Where we are with complaints is for the highs, we do believe that we are going to have those cleared, that backlog cleared by December. For the medium and the low complaints that we still have, those we have gotten guidance from CMS can be rolled into the annual complaints, the annual surveys. So as soon as we're able to resume those, we anticipate that those medium and high complaints will be resolved as well.
But that means that if a family member complains, like this month, and then that facility is not expected to have their annual for another 12 months, that family member may not see a resolution then or an investigation for 12 months? Is that what that?
No, that's not what it means. So when I was talking about the 64 highs, the 34 mediums, these are the backlog ones that we're talking about, right? So what we're doing is because we have additional staff and we have the contractor staff, now we are able to go in as we should be going in on our regular schedule, right? So what that means is that if a family member complains and it's a low priority complaint, we don't have to roll it into the annual survey. We can go into that facility earlier, probably within about 45 days usually is what it takes. But because we are working through the backlog of complaints, it has been taking a little longer, and we've been rolling that into our annual surveys.
Okay. I think maybe if you're able to get us follow-up data, I think I'd be interested in also seeing some of the complaint-based data and the backlogs. I think we do hear from constituents quite a bit about, the situation in facilities where their loved ones are residing. And so I think those concerns that they reach out to us about, I fall under that set of investigations or inspections as opposed to the annual ones, which of course could prevent that set. But so if you can provide us with some follow-up information, please, on the complaints and where those are at. And then I'd also, either in the next few months, if you're able to, I am interested in the focus on the improvement in the quality of the process that you're going through. And so, obviously, we're focused more on the numbers because it's alarming to have, so many in a backlog. But it's good to hear about the improvements in the quality, and I think we'd love to sort of hear more about what it is that is put into place that you feel like is kind of creating a higher quality inspection. So if we could get those as follow-up. Thank you. Chair Hester.
Yeah, I had a similar line of questioning, and just to clarify, when you're getting Chair Charkoudian the additional information, I'd really like to see like high, medium, and low, the number of complaints, examples of the types of complaints, and then when you're planning to do them. Because I thought I heard it was going to take a year, and then I thought I heard it was going to take 45 days. And I'm still slightly confused as to which one that could be. So like a chart would be very, very helpful. My second question was about you said a couple times that we're on pause with CMS with the annual surveys. Is that because the government is shut down?
Correct.
So as soon as the government opens up, you should be able to, okay,
Correct. We are, yeah.
thank you.
Thank you. Two questions. One, just to follow up with Senator Hester's question regarding when you resume, that means that you'll still have more of a backlog, correct? Because you're not doing anything now, so the complaints are coming in that you're going to be rolling into your annual surveys. So it's almost like we'll never get out of the hole. Is that a correct or semi-correct assumption?
So I think first to clarify, with the shutdown, there are some accepted activities, which includes immediate jeopardy or what is called non-IJ high complaints. And the team has been very focused on doing all of those and continuing to address or to make sure that we are fully caught up on those. You are correct, and I know Director Witherspoon and I have been talking every day about this, right? That not only, unfortunately with the pause, not only can we not do the backlog, but there are some facilities that would be due for inspections over the next, several weeks or months that, at least right now, we are on pause. I will say, again, we are having very frequent conversations with CMS the day, right, that we are allowed to go back in. We are committed to, and I think have got ourselves into a good place where we will work as hard as we can and have those efficiencies built in to hopefully be able to catch up, but we will continue to keep you updated, and part of it depends, right, on how long the shutdown continues.
Thank you. And that rolls into my second question. Can you explain what immediate immediate jeopardy is, or what it looks like? Because you said it'll take 2 to 3 business days before you get to whatever that is. So can you help me to understand what immediate jeopardy looks like?
So immediate jeopardy is kind of the most severe and egregious types of complaints where there has been potential or actual harm to a resident. So when we're getting those types of concerns or reports into us, we are triaging it. We have a nurse that is triaging that. And if we feel that it rises to that level, we are getting a team out there pretty quickly to investigate.
So if a complaint about regarding immediate jeopardy comes in on a Friday afternoon, potentially you may not be there until Wednesday.
So if it's an immediate jeopardy, we do surveys on the weekend as well. We do off-hour surveys, and we are required to do a certain amount of surveys on the weekend. So if we feel that situation is rising to the level of immediate jeopardy, we could go out there on the weekend. If we feel also that it's widespread and it's severe enough and it's something that's maybe affecting more than one resident, that resident is still there. There are different factors that will play into it. There are some times where a resident could have something happen at the facility and maybe they went to the hospital. So in that case, that resident is no longer in jeopardy. But if we feel that they are still there at the facility, they are in jeopardy, it could be affecting other residents or impacting other residents, we can go out there on the weekend, and we have done that.
Okay, because you said 2 to 3 business days, that's basically Monday through Friday. And so I just wanted clarification around that.
There are exceptions to it. If we feel that it is, dire need, we can definitely go out on the weekends.
Thank you.
I think I had one last follow-up question. When the inspections happen, are the results public, or what is public about, what can the general public sort of access about the findings?
Yeah, so the results are public. We do what's called a 2567, which is a detailed list of everything that we cite. That is public. You can find that information on CMS Care Compare. And we also will post the plans of correction. So all of that information will be public for everyone to see.
Thank you. Are there any other questions?
I have one last
Yeah,
one.
good.
So Senator Benson, I know, cares about this issue very, very much. At the last meeting, she had asked, she was concerned about the out-of-state or private equity ownership affecting the quality of care and accountability in our nursing homes. I'm curious if you guys have looked into that at all since that last hearing, and if you could enlighten us as to whether there's an issue there we should be concerned about.
We have. So as of, we were seeing about 12 requests a year for change of ownerships. Recently, there was new regulations passed with the Maryland Healthcare Commission. That was back in February. And since that time, we have seen a drastic decrease in the number of private equity firms and change of ownership requests. Since March, we've received one, which is definitely a much lower pace than what we were seeing before. Right now, it looks as if, that could have been a contributing factor. The strengthening of the oversight of the regulations could have been something that contributed to this. I would need a little bit more time to say definitively, but we have definitely seen a drastic decrease in the number of change in ownership requests that we've received.
Thank you. I'll let her know.
Thank you. Well, thanks for that presentation, and let's move on to the Clifton T. Perkins Hospital Center progress report.
Dr. Everett and as Dr. Everett and Dr. Jones join me up here. So just to tee this up, so I think, in particular, when I met with Senator Lamb as I was doing my confirmation process, the issues at Clifton T. Perkins were front and center. And I will say, as someone who, before coming to this role, I was in the system leadership for MedStar Health, practicing as a physician, leading in a health system. This is all very important to me, and I feel fortunate to be able to bring some of that experience as well to bear. And in part, that has led to some of the changes that you have seen with the leadership, bringing Dr. Jones on board for Clifton T. Perkins and bringing Dr. Everett on board to, bring back that kind of system-wide look at our facilities and how we can most effectively improve them. I am very heartened to have seen the changes that have already been put in place by Dr. Jones and Dr. Everett. And, we will speak to some of that and know that there continues to be work that we will all do together here. So I'll turn things over to Dr. Everett and then to Dr. Jones to discuss progress to date at Clifton T. Perkins.
Thank you, and thank you, Madam Secretary and committee, for your interest in our system. So I've been on the job for 3 months, so to speak. I've come from a longstanding history of working in leadership roles and primarily in public-funded facilities and outpatient centers. So that's part of my experience. Just want to give everybody a context, a reminder that the system per se includes 5 hospitals. Perkins is one among the 5 hospitals that Maryland operates. And then there are also 6 additional facilities that are all in my responsibility. Our current capacity for adults. I'm sure. Hello? Is that better? Yeah, okay. Our current capacity for adults is that we have just over 1,000 beds across these 5 facilities. Perkins itself has 289 of the beds, of the 1,000 or so beds. Virtually all the patients in our system right now, the system that Maryland operates directly, are court-ordered. So every single patient at this point in time is there because they're associated with a crime and associated with a mental illness. I'm really pleased and thrilled, and part of my reason for accepting this position, which has great responsibility associated with it, is knowing that we have some great solutions put in place in our system, and Dr. Jones is one of those. I think you'll see as you meet her in the role she's in now, and as you hear her presentation, you will realize that she has both the education as well as experience to lead one of our most historically challenged institutions. As many of you know also, and as you listen to her presentation, I'd like to invite you to think about the prospect of the deep change that Dr. Jones is really leading at the facility. This deep change at Perkins will take a while to get there. Deep change, of course, takes a minute. There are several hundred, up to 500 or so staff involved in the changes that she is going to be making, has already initiated and will be making, and we're very proud of the work that she's done so far and looking forward to following that together with her, the work that she will be doing. So with that, I introduce to you Dr. Jones.
Thank you, Dr. Everett and Secretary Seshamani, for your faith and your confidence, and thank you so much for all of you for your concern and your support of what we're doing at Clifton T. Perkins Hospital. As introduced, my name is Dr. Aaliyah Jones, and I am the CEO. I'm glad to be before you this morning to provide you an update on the hospital since my arrival in mid-February 2025. Next slide. Accepting this position at the time that I did when the hospital was going through so much public and private turmoil, as you all are well aware, it was clear to me that the hospital needed a fresh start and to turn the page. And so there was an existing mission and vision that was already in place before I walked through the door. However, I decided to reformulate that based upon what I knew the promise of the hospital was. Next slide. So a good mission statement communicates what we do. Our new mission was formulated to more greatly encapsulate the robust function of our hospital and our focus during my tenure and into the future. Next slide. Our vision statement communicates what we expect to be the outcome of accomplishing our mission. Next slide. Perkins has a history of being an internationally recognized institution for the treatment of forensic psychiatric patients, those whose illnesses have caused them to commit the most heinous and egregious of crimes, and for the training of the next generation of forensic psychiatry, nursing, and healthcare leadership. That was my first introduction to the hospital system in 2001 when I moved to Maryland to begin my psychiatry residency training at the University of Maryland Sheppard Pratt as a psychiatry resident. Next slide. How can we go about achieving our mission and our vision? Perkins' previous values were safety, integrity, competency, just culture, diversity, and innovation. It's clear that the organization was not living up to those values. I believe that acting on a new set of values will help us to align with our mission and our vision and achieve what we know that the hospital can do. Next slide. We will treat every individual, patient, and staff alike with empathy and dignity. We are dedicated to the highest standards in patient care, clinical training, research, and operations. We will prioritize safety and hold ourselves to transparent, rigorous standards. We will act with integrity, honesty, fairness, and ethical responsibility. We will engage across all disciplines and systems to provide coordinated care, and we will embrace evidence-based practices and professional growth to drive improvement. Next slide. There has been an extensive amount of turnover in the executive leadership at the hospital. By way of background, you know a little bit about me. However, what you might not know is that I'm an addiction psychiatrist by background, triple board certified in adult psychiatry, addiction psychiatry, and addiction medicine. I have an executive MBA from Robert H. Smith School of Business, which is for the University of Maryland, and I have 10 years of hospital senior leadership experience between Bon Secours Hospital, well, what was Bon Secours Hospital, and most recently Luminous Health. Our Chief Financial Officer, who's been in place since January of 2025, is also an extensive state of Maryland employee. He's worked for the state of Maryland for the past 31 years, most recently serving as the CFO for Spring Grove Hospital since 2015. Rod Fuentes, one of my first hires, is a veteran of the United States Army, experienced in multi-site companies, tertiary and acute care teaching hospitals within regional and national health systems. And Evangeline Okechukwu, who is our acting director of nursing, has a PhD in nursing from The Ohio State University. She's been a state of Maryland employee since the year 2000 and has worked in various nursing roles at Perkins since 2008. She's also worked at the Shepherd Pratt Health System. Next slide. My leadership came at a pivotal point. The hospital was facing very significant challenges related to workforce stability, infrastructure deterioration, and declining staff morale. Most recently, the hospital had been plagued with a number of explosive articles in the Washington Post about all of these challenges and others that raised serious concern about the safety of the hospital environment. In the background, there continued to be and continues to be issues around accessibility of the facility to citizens awaiting beds. My appointment signaled a renewed commitment to restoring safety, accountability, and excellence in patient care. And what did I find when I got here? I found the things that you see on the slide before you, including vacancy-driven overtime, policy confusion contributing to operational risk, and critical infrastructure failures. What I also found, however, was a wonderful team of dedicated and committed workers who are committed to the patients and who are committed to one another. Very, very many long-tenured employees who express significant readiness and willingness to change. Next slide. From April 1st to 4th of 2025, the Joint Commission was on grounds, and based upon, they were there for our regular triennial survey. Based upon that accreditation survey, our application for reaccreditation was preliminarily denied, pending a successful abatement survey to address several threats or immediate threats to health and safety. The preliminary denial was due to environmental and infection control issues that were felt to pose an immediate threat to the health and safety of the patients. We got immediate support from the Department of Health, even while the Joint Commission was on grounds when we had concerns that we were not going to have a constructive or a positive survey. The support from the department included deploying the Department of Public Health resources to ensure the safety of the facility for the patients and staff, and to provide guidance around infection control precautions. We got support from the Office of Facilities Management and Development around mold abatement and rust removal throughout the campus. And we had realignment of our pre-existing HVAC project to expedite repair of the exhaust system to prevent mold regrowth throughout the facility through the Department of General Services. We have also had constant support on the ground from our on-the-ground facilities team and EOC teams. And our regular contact with the Joint Commission and with the department, because of that regular contact and the support that we had, we were able to have a successful abatement survey in August of 2025, retaining our Joint Commission accreditation, primarily because of the demonstration that we had to, and the commitment that we had in the department's support to addressing the myriad issues on the ground of the facility. Next slide. As you saw, we are prioritizing safety and accountability, and as an organizational value, we are supporting these values in many ways to foster a culture of safety and accountability. Next slide. Construction activities, I'm sure that you are aware of, began because of the multiple critical system failures and deferred maintenance requiring state attention and assistance to remediate and abate. The Department of General Services is the entity that holds the contract for the HVAC component replacement project. The Office of Facilities Management and Development from MDH holds the HVAC emergency procurement contract, and there's a partnership with the Department of General Services and MDH for overall development and management of the hospital's HVAC needs. We have biweekly meetings on site at Perkins with the contractor and the relevant stakeholders. In this particular slide, what you see is a cooling tower which contains chillers that needed to be replaced or repaired. Next slide. Our boilers were the original boilers of the facility that opened in 1965. They were finally removed last month, and we currently have 2 temporary boilers, which are in the first image of the slide. Next slide. And our new boilers were installed a few weeks ago, and they will become operational starting December 2025. They're the pretty blue circles on the bottom right, in the bottom right image. Next slide. This is a huge multi-step project that began in late 2024 and is expected to be completed in August 2026. Given the state of the neglect of the facility for so many years and the complexity of this project, sometimes when one component of the project starts, there are unanticipated downstream negative impacts that have to be addressed. We try to identify and manage these issues quickly and as a larger team with all of our relevant stakeholders. Next slide. To realize our previously referenced mission and vision, we must align our daily operational and long-term planning and cultural transformation around a clear, focused set of priorities. These priorities are articulated through 5 strategic pillars, which will serve as the foundation for the hospital's recovery, growth, and sustained excellence. While each pillar is distinct, they are interdependent, and success in one reinforces success in all the others. Next slide. This slide was formulated about 2 months ago at this point. However, as you can see, I hit the ground running, and we have been steadily working towards delivering on our mission, vision, and values. Next slide. We have significantly invested time and resources in actively recruiting for all of our vacant departmental positions. Our goal has been to onboard individuals who not only meet technical requirements, but also align with our departmental values and commitment to patient care. We have strengthened our recruitment efforts by collaborating with our on-site with OHR, and for on-site and community fairs, and by participating in outreach efforts. Next slide. Since my arrival in February, we have been laser focused on our vacancy rate and have seen significant improvements. Next slide. This slide shows a comparison for the time period of January through September 2024 to 2025 regarding patient-to-patient assaults. Our patient-to-patient assault data indicates that there has been a decrease of 40% in patient-on-patient assaults as of September 2025 in comparison to 2024. There was an increase in August, if you're looking closely, and that's thought to be due in part to the increased number of admissions to our admissions units. We had 15 admissions in the month of August, which is significantly higher than the number of our typical standard month of 9 admissions per month. Next slide. Patient-to-patient staff data also shows that there is a significant increase by numbers of 32%, decrease, a significant decrease in patient-to-staff assaults of 32% over the same time period, which has been most notable since April of this year. Next slide. Right relationships are the foundation of improved communications between team members and standards of behavior that we expect amongst one another. This document, or a document that contains right behaviors, is shared with all of our new employees during their orientation. And when I first came to the hospital to try to address some of the toxicity in the environment, we started all of our meetings with this reading, and we've embedded the practice of starting all of our meetings with a moment of reflection to set a constructive tone for all interactions. Next slide. At Perkins, we've launched a 2-tiered internal newsletter strategy that has become the cornerstone of our internal communications, engagement, and transparency efforts. Both newsletters reinforce our vision, values, and strategic pillars. Our weekly newsletter has been published continuously since my arrival in February, and we started a monthly newsletter in June, which goes into a bit more depth about various topics of interest to our staff. Next slide. There exists at the state hospitals a culture of calling out of work, and one such incident on one particular evening directly led to a staff injury. And so I initiated a response in partnership with the hospital leadership called Cultivating Dependable Citizenship campaign. And this campaign aims to foster dependability and accountability through various initiatives, including data tracking, so we have better recognition of, and so that we can recognize people who are accountable and those who are not, with presenteeism, recognition for those who are accountable by showing up when we need them to, and a culture and messaging campaign to really undergird and support the concept of being there for one another and the importance of the team showing up when we need them to. Next slide. I personally lead the Culture and Messaging Initiative along with our Director of Social Work, and we created Dependable Citizenship Month, which was and will be an annual event at Clifton T. Perkins Hospital. It just ended a few weeks ago. This and other initiatives continue to improve staff morale, with people expressing greater happiness to come to work and a reduction in mandated overtime. It is very important that we recognize and appreciate staff who work in our very challenging work environment and even on a good day, it's a challenging environment in which to work. Next slide. These are some of our team members who were named directly as being dependable team members. The team was able to respond to a survey. We do a lot of surveys to get the employee voice about who they felt were the people that they could count on amongst their peers. And they named 65 individuals, distinct individuals, and these are some of those individuals. Next slide. This is information about our Employee Engagement Committee, which self-started in April of this past year. I personally believe that work should be fun. The work that we do is hard, and it's serious. However, people should enjoy what they do nonetheless because they do their work better if they're enjoying what they do. And so we are trying to cultivate joy in the workplace, and I'm really excited about our engagement committee and all the work that they're doing and how motivated they are and how much joy they bring to our work environment. Next slide. Despite the real and regular challenges, I remain very optimistic about the future of Perkins Hospital. We do indeed have a long way to go. However, with the continued support of the department, which I know that we have, and other key stakeholders such as yourself, I know that we'll be able to take the hospital back to its previous heights, if not higher. Thank you.
Thank you. Do committee members have questions? Senator Lamb.
Sure. Thank you, Chair Cherkourian. So it sounds like a lot going on here at Perkins, and hopefully, it's signs of kind of righting the ship, so to speak, there. I think one of the things that had come up in some of the prior reviews of Perkins is just a reporting structure back to the secretary that, was probably deficient in some ways, that that there wasn't adequate notification to the secretary on significant incidents or patient deaths that occur. I think at least I had heard that there was another patient death a month or two ago that had taken place. I don't know if there's anything that you can speak to on that case, but are you able to assure us that significant events like that are properly reported up the chain to the secretary?
Yes. Well, can I?
Go ahead if you want to start.
I don't have any, I have a ready line to Secretary Seshamani. We have ready means of communication. I probably sometimes feel like I over-communicate when there are things happening on the ground that I think that she should be aware of. She and her team have been very supportive whenever I've raised my hand and said, this is something going on. Either A, you should be aware, or B, we need help managing an issue or a problem. So we have ready communication 24 hours a day, and she has made herself very accessible and interested in knowing what is happening at the facility. She and also Dr. Everett, since her arrival as well. I'm very familiar with her team. They're of great help and resource to us.
Yeah, and I would say, Senator Lamb, in my prior leadership experience in a health system, I worked on, quality and safety improvement. And one of the big opportunities there is creating a culture where people feel that they can raise their hand and express when things are not going well. And I think that underlies a lot of what you have heard from Dr. Jones about the culture change that she has been putting in place at Perkins, where again, she's wearing her bracelet, you can depend on me, because it is about, we want to hear from you because then we want to be able to support you. And so at a system level, I get weekly updates on incidents across the system. I get numbers, I get information on types of incidents, and as Dr. Jones mentioned, and Dr. Everett can speak, they also reach out directly for some of those kind of higher level incidents as well, so that we can make sure that we're addressing at the front end. And the other thing that I will say is, I think it's really important that people know that this is not just words, that it's actually actions. I actually think the first visit that I made as secretary was going out to Perkins, in part because of what I heard from you, what I heard from others, that I thought this is really an opportunity to put my body where the words are, right? And to say, you are important, we want to work together. I have made several visits to Perkins, I have met with staff, I have met with unions, I've met with the leadership, because again, I think it's important that we have that sense of that openness to be able to communicate and have those conversations about where there are opportunities for improvement and really partnering together on it.
Okay, and I think one of the other prior areas that we had viewed as challenging were just staffing needs, to make sure that there was adequate staff to cover, that we had also been seeing a lot of overtime being clocked at Perkins. And, I think part of the concern is that, people were being pulled in, or there were a lot of call-outs, and then people were mandatorily being called in. All of that was leading to, kind of cascading overtime at significant cost. And, potentially leading to safety issues that I know, for workers there, that's really important to have adequate staffing levels as well. And, the higher need for overtime probably exacerbates that. What have you done to address kind of those staffing needs? And do you feel that you have adequate staff now? What other resources can we provide?
I'll let you know that that's a work in it's a work in place right now. And some of our hospitals across the 5 hospitals have varying degrees of difficulty in hiring people, but we are working on it actively. Perkins in particular has difficulty attracting individuals, and so it's a work in process. We've put a lot of effort into it. Melissa will tell you a little bit about some of the job fairs and things like that we've had to associate it or to work with it. But it is a challenging workforce, and we know that. That being said, the culture that Dr. Jones is working on developing is very promising, and will make it the kind of place that people like to go, like to show up, because there is an approach that is calm, thoughtful, and joyful in the workplace, despite even the difficulty with some of the patients.
And I will say that I appreciate you asking what help can what things can we work on together, because I think this is an ongoing issue that it will be great to be able to continue to partner as well.
Maybe if you can kind of elaborate on that just a little bit, how far do we have to go to reach adequate staffing in your view? Are we 80% of there, 90% of the way there? How many staff do we think we need, and what can we help with getting us there? Is it additional pins? Is it additional salary support? This is obviously a challenging environment. A lot of folks may not want to work there. How do you attract talent to go work in a very difficult environment? What can we do? Is there anything specific that you can offer us?
Sure. So salary support definitely is something that we need. My HR counterparts can speak to this more clearly, but there was a legislation that was passed several years ago that leveled up the salary for those who work at the state psychiatric facilities, giving them the CI designation, criminally involved or court involved designation. And prior to that elevation of salaries across the board, there was a pay differential for those who were working at Clifton T. Perkins Hospital. When the CI designation came into place, that differential went away. So everyone got an increase, but those who work at Clifton T. Perkins, their salaries essentially stayed the same. And from a comparison perspective, from an opportunity perspective, it decreased because they lost that differential. And so that meant that you can get paid to do this, to the same amount of money working in a less risky environment. And so unless you're hyper motivated to work at a place like Perkins, it makes more sense to go work at a regional facility because you can make the same amount of money and be at less personal risk to yourself. Having a differential would be very, very helpful for us to have the differential back so that we could separate ourselves because we are different from the other facilities. We are the only maximum security facility in the state of Maryland, taking the highest risk individuals, the individuals that are most difficult to manage. And so having that differential would go a long way towards helping us with our recruitment. That's why we had the differential in the first place, and we have suffered because of that in part.
And I think to build off of this specific example that Dr. Jones gave, we are working with AFSCME right now on a staffing survey so that we can get a better sense of where we're at and where do we need to go, that I think will be very helpful for our ongoing conversations about how we continue to improve staffing at our facilities.
I know the staffing survey sounds like it's still in the works, but do we know how far along we are right now to adequate staffing? Or is that survey intended to give you a sense of what adequate staffing is?
Yes, in part that is exactly to get a sense on the ground of where we are at and where we need to be, looking across different types of staffing as well.
So you're still trying to figure out what the appropriate staffing is?
So I think we can safely say that there are opportunities for improvement in staffing, absolutely. And that's where I appreciate you asking the question, because I think this is something that we need to continue to figure out. And I think in terms of getting into the more granularity of exactly what is needed, that's where we wanted to be able to engage in a collaborative way to get to what is actually needed, because we can say, okay, let's have so many pins or let's have so much money, but we want to make sure it's being directed in the most appropriate way. So that is the purpose of doing these surveys. But, Melissa and Dr. Everett, you should chime in.
When do you expect that survey to be completed?
So we are just at the onset of it. I signed a letter with Jenny Reese, who is the Chief Steward for Department of Health for AFSCME. So we just finalized the letter yesterday to get out to the facilities to let them know that we're going to start kicking that staffing analysis off and the support that we need from the facilities to make it an effective analysis.
Okay. Last question then is, I know there was a outside consultant report that was done, I think about a year ago after they came in to look at Perkins. We have never been able to see or even get a summary of that outside consultant report. Is that something that you can share with us?
That is something that we have been working with, our legal team, because I think there are things in there that, we have been told, is confidential, and we can continue to circle back and see what can be shared. What I will say is that we are absolutely making improvements based on what has been what have been some of those findings. And that includes things like when I went out in my second week on the job, going and seeing the mold and seeing where remediation is done, and then going back out and seeing the new boilers and talking to the staff, okay, where have there been improvements to date? Where have there not? So that we can continue to iterate on this. Okay.
Well, even if you can provide in summary form, that's the same answer that we got about 10 months ago, that there's a legal review going on. We're not asking for patient confidential information, but I think even at a high level, that would be helpful for us to know, what the surveyors were looking at, what the consultants recommended, so that we can take it back, work with our colleagues in Budget and Tax, and see if there are resources that we can provide to all of you as well. But I think that would be really, really helpful.
Thank you, Madam Chair. I have 2 questions. My first is keeping in line with the staffing questions. It's my understanding that security personnel were receiving a 6-week correctional certification, and that's been downgraded to only just 1 week, and the staff currently feel that this is inadequate. Are there plans to bring back correctional certification?
So I certainly, so the reason why that changed, again, I think had something to do with when all of the hospital facility, So the reason why that changed was because there was the expectation that all security personnel across all of the state hospitals had to have access to the same training, regardless of the environment in which they worked. And it was cost prohibitive for everyone to have the training, and so the Perkins staff lost that training. My team members feel very, very strongly about the caliber of the employee that you have that gets developed through having that experience. I think it would be important for us to bring that experience back, and I believe that Dr. Everett and Secretary Seshmani also support that as well. And so that's something that we are looking into, if that's something that we can do.
Fabulous. If you could get back to us with a timeline for that, once you've had your internal conversations, that would be helpful. My second question is the boiler. So I heard you guys say that the boiler, it was the original boiler from 1965, which means the boiler was 60 years old. And there's a number of issues with this, but the general life expectancy of a commercial boiler is 25, maybe 30 years. So like, this is like an antique in the basement of Perkins. Now, I believe that boilers are covered under statute in Public Safety 12, Building and Material Codes and other safety provisions. Subtitle 9 is Boiler and Pressure Vessel Safety Act, and subsection 12 is inspections, which is all done by the Department of Labor, unless there's a private inspector. So like, how did we get to the point where we had a 60-year-old boiler? Were inspections happening annually? Was there a request from Perkins to upgrade the boiler? I mean, literally breaking state law here, I believe. And then my follow-up question is going to be like, how old are the boilers in your other facilities? And like, are they being inspected regularly? I mean, this is really, really, I mean, that doesn't, I'm not even talking about the mold and HVAC. I'm just talking about one boiler, which was a safety issue.
I can tell you that we can get details of that, but many of them are very old and past life expectancy in a couple of the other facilities as well.
We have a state chief boiler inspector. Had they like not been out to inspect the boilers?
I don't think that any of us can speak to that particular issue. I think it's one of the myriad issues with regards to the neglect of the facilities over decades. I mean, the challenges that we have at our facility are not because the facility was neglected for the past 2 or 3 years. It's because the facility had been neglected for dozens of years. What we are working to do is we're working with our partners in OFMD to get and they can speak probably more fluently to this because I'm not the COO, I'm not acting in that capacity anymore. But we're to create a contracting vehicle so that we do have an external partner who can help us with the facilities management and oversight of our critical infrastructure to ensure that we don't find ourselves in positions like that we're in right now. It does require significant, not only inspections, but regular maintenance, and the maintenance does not appear to have been happening. And so we are creating a vehicle that will allow us to have appropriate regular maintenance of the systems that we're putting into the facility as it stands right now with the new HVAC system, and then all the other systems that currently exist as well.
And I will say this is where we look forward to continuing to partner with you, because we are identifying issues with maintenance and issues with where we need to upgrade our capital, that it will be good to be able to partner with you on those plans. We have to prioritize. We all know the budget situation that we're in, and there are things that need to happen, and we want to work with you on those.
I would welcome that conversation. I mean, I think we probably should include DGS, OMB, and the Department of Labor, because it's just, I mean, you got to start with it. You got to triage your buildings, I guess, but we can't have, antique boilers which could explode and kill people in the basement of these buildings. So looking forward to continuing the conversation.
I'll pick up on some of those same points first. I think coming back to the question, maybe Senator Lamb asked earlier on the other piece of it, but I think I am interested in understanding this question about like, how did we get here? So like the question about deferred maintenance, unfortunately, we've seen that in transit. We've seen that, like this administration inherited a lot of deferred maintenance. But in this case, you're talking about, like that, then the light rail, stops functioning at some point, that kind of thing. But in this case, you're talking about if it's 25 years, whatever it is, like 40 years of deferred maintenance, right? And I think I would really be interested in, and perhaps it is a conversation with DGS, but I would really be interested in understanding from your perspective for a building that you're responsible for and responsible for the health of people inside that building with all of these environmental health issues that are reflected here. Like, how does that happen? Like, do you all send an email saying, could we get a new boiler? And they're like, nope, you got to wait another 40. Like, I'm actually trying to understand how that can happen. How are we here? And did we see a budget that said you need a new boiler? And we were like, no, wait another 40 years. And you may have the answer now. I'm interested in understanding. If you don't have it now, I do think that is something that needs to be a little more explicit so we figure out how 40 years past the date that a boiler should have been replaced. It was replaced not because our systems worked, but because this joint commission was going to fail a hospital because of the dangers that it presented, no?
No. So the plan to replace the boilers was a part of the whole HVAC system renovation, and that was all approved in 2024 before this Joint Commission survey.
Okay, but it was still, at that point, 59 years old.
Correct.
Yes,
So I think,
yes.
I agree. I think this is something that we can follow up and work through. I completely hear what you're saying, right? Like, how do you get to this point? It comes back to Senator Lamb, what you were saying, so that you can potentially prevent something like that from happening again in the future. And I think, this is where a partnership is important, because as you hopefully see, we are doing everything we can to right the ship from our end, and I think there are certainly opportunities for partnership with you. So I think that's something that, we certainly will circle back, similar to the OHCQ issue. But I think, Dr. Jones, had a good flag that, yes, these were, I think, as you put it, Senator Hester, past where, the replacement time that was in the works, though, finally, and then the situation happened.
And I think, and I think we all know that replacement in crisis points, or God forbid, explosions, and complete malfunction are more expensive than maintenance over time, even though in the short term that might seem like a good way to, cut budgets. I guess, so we're definitely interested in that as a follow-up. I'm interested, though, broadly in the environmental health metrics. So I can see a number of things specific to mold and rust and air quality testing, that there's ongoing remediation, and it does appear that, just based on my limited understanding of HVAC equipment, the steps that you've taken and are going to take will address a lot of, and the remediation will address a lot of the air quality and indoor environmental health issues. I'm just wondering if you have those metrics. Like, what are the metrics of indoor air quality and other sort of environmental particulate, those kinds of metrics that you're testing on a regular basis? Are those public? Is that something we can see the improvement of? What are our baselines?
I'd have to get back to you on that one. I do know that we are, when we are addressing the mold issue, we do have a contractor that is coming back to test to ensure that the mold has actually been abated and destroyed, and whether whether a remediation needs to happen more immediately, or whether that can be delayed in the event that the mold does return. So from that perspective, I'm aware of our testing of those locations for the presence of mold. As it pertains to air quality testing, I'd have to get back to you on that one. I need to look into that. I do know that we had the Department of Public Health came out when in April and maybe a couple of times around that time because of the concerns of the Joint Commission around the air and the testing or the assessment of the team at that time said that the air was safe to breathe, okay? So that we knew was safe and that the levels of mold in the facility were lower than the levels of mold outside of the facility. And so we did not have a true air quality risk from that perspective. And we also make sure that as a part of our remediation for the mold, whenever the mold is actually being abated and being released into the airflow, we have air scrubbers that we're using to ensure that the air is clean in that space, and those spaces are closed off from patients and from staff. So we're taking all of those precautions to ensure that as we're treating the mold, that we're not causing any additional problems, and we're also monitoring our patients as well for any changes in health. And the same thing would be true for the staff if for any changes in health related to any mold-related issues. And we have not seen any issues with patient or staff from mold-related concerns that have been that have risen to us, and we are paying very close attention to that. But anything else, any other testing other than that, I'd have to look into that for you.
Okay, yeah, that would be good if you could. And then I think I want to talk about some of the staffing issues as well. So you've got, you talked about a couple of things that affect staffing. You mentioned some of what you're doing to recruit. You talked about the culture you're trying to create. I guess I'm wondering, the pay differential, for example, was one very specific thing that you said you thought could make a difference. I'm just wondering if you know yet, if you can talk about how your budget requests will reflect what you think is needed to address the staffing. Obviously, the trends are going in the right direction, but probably more slowly than anyone would want, especially given the history and the safety concerns and so on. And so I'm just wondering, pay differential or other things that you think could make a difference, can we expect to see that in your budget requests so that, to Senator Lamb's point, we can work with our colleagues on the budget committees, appropriations committee, to support that?
Yeah, these are things that absolutely we are working through with our Department of Management and Budget. We are bringing forward our budget thoughts to them and working through it, and we'll be bringing things to you. But this is absolutely part of the conversations that we're having with our Department of Management and Budget management.
Well, I think, one of the things that sometimes is challenging from our perspective is we'll have an oversight hearing with an agency, fill in the blank, any agency, who will say, like, here's the problem, this is what we need, but then we'll see the budget request that comes from that agency that doesn't reflect that. And so potentially, we do have the ability to move money around, but when the request isn't reflective of what the agency is saying is needed, it's harder to sort of close that gap from the budget perspective. So to your point about our ability to work in partnership, which I certainly hope so, it's easier for us to support that if your budget requests or the legislation that you're putting forward as a department is reflective of those actual needs. So that would be my request, and to the extent that you have the ability, once you know what that budget request looks like, to let this committee know where we can see this specifically, like the needs of this hospital to address the historical health and safety issues in this hospital, we would be interested in seeing that as a committee.
Just to quickly follow up, we do understand that the department's budget requests are not always approved by the governor, but after the budget's been published, then it would be helpful to know what you actually need to fix the problem.
Yeah. Anyone else? Okay. Then we will move on to the last section, which is, do you have a change in?
Nope, she's sitting right here.
Okay, there you go, human resources update.
Yes, exactly. So, I will say that I have heard from several people what a great HR head that we have, where she really does work to get to yes. in a myriad of constraints and challenges that we are dealing with. I don't know if you have heard that from me directly, so now you've heard it in front of everyone. But certainly, we are in a challenging time. And I think Melissa can speak to how we are working through that. And that ties into the conversation that we were just having about prioritizing, both where we are getting exemptions from a hiring freeze to how are we really engaging in terms of our recruitment and retention to both fill vacancies and to make sure that, the Maryland Department of Health is a great place to work that people want to work at.
Thank you. So my name is Melissa Easley. I have been with the Department of Health for 20 years now, but in this role for a little under 1 year. So I'm excited to give some updates. These are mainly surrounding recruitment and our 24/7 facilities. Next slide. Okay. So first, just wanted to highlight that although the Department of Budget and Management, they do maintain a list of classifications that are exempt from the hiring freeze, the majority of our classifications, especially in our 24/7 facilities, do have an exemption, meaning that they do not have to go through the hiring freeze exemption process to begin recruiting and filling for those positions. About 60% of our positions are exempt, while about 40% of them are non-exempt, and they fall more in the administrative or technical classifications. Also, just wanted to highlight that we have also received blanket exemptions for certain specially funded positions and administrations that also help with our recruitment efforts. Overall, from the VSP impact, 47 MDH voluntary separation program applicants were approved, with only 6 of them being in exempt positions. Next slide. As of October 15th, our vacancy rate for the department, so headquarters administrations along with our facilities, is at 13.9%, which is a reduction from last year. And we are seeing strong results in various facilities demonstrating that our targeted efforts are working. There is a list here of the current vacancy rates as of October 15th for each facility. And I would like to highlight, like Spring Grove Hospital Center, one of our central region hospitals, is down to 8%, Holly Center 8.2%. And again, these lower vacancy rates confirm that focused recruitment and retention strategies are working. Next slide. This slide will provide an overview of merit positions and vacancy rate details. MDH is currently tracking 7,411 merit positions. We've also filled 49 of the 89 security positions that were newly added at Perkins. And while the vacancy rate at Perkins is a bit higher, it has reduced significantly from this time last year, even with those newly added PINs. I believe last year we were at over 26%, and now we're at about 17%. Next slide. Some of our hiring initiatives that we have put forth is that we have established an ongoing HR committee that's dedicated specifically to addressing hard-to-fill vacancies, ensuring continuous high-level attention to these challenges. Our approach is modern and proactive. We are streamlining recruitment and outreach strategies to attract high-quality candidates and actively engaging with passive talent pools. We are prioritizing job postings for especially challenging to fill positions to ensure resources are focused where they needed most. And we are using social media to highlight employment opportunities and leveraging our internship program as a strategic pipeline for attracting and developing top talent within the state. Next slide. Some of our outreach that we utilize a broad, multifaceted approach to ensure we reach diverse candidate pools. So we are utilizing job slots, LinkedIn, social media highlights, employing our professional digital tools, like I said, LinkedIn job slots and various social media platforms to highlight employment opportunities effectively. Our outreach is not limited to experienced professionals. We are also strategically targeting future talent, attending high schools and colleges, We have prioritized the development of comprehensive recruitment strategies, which include specific advertising suggestions, ensuring that a strategic and consistent message across all channels. Next slide. One of our biggest highlights are the job fairs that we have been participating in. So our outreach, we have attended 46 job fairs since September of 2024. Highlighting our hard-to-fill facilities at the said job fairs. We have also targeted on-site career fairs at the facilities, such as Clifton T. Perkins Hospital Center and Spring Grove Hospital Center. These targeted events are highly successful because they focus specifically on filling our most critical needs. So, for example, at Clifton T. Perkins, we've already had 3 on-site job fairs where we had like flagged and highlighted different clinical or security positions. We had a success rate of 27% of the filled positions in our clinical and security came from the on-site job fairs, where we also hosted on-site interviews at the time of the job fair. We also hosted an on-site job fair at Spring Grove in March of 2025. So again, a key strength of these events is the inclusion of on-site interviews, coming to the actual location to see where you're going to work, and meeting some of the leadership at the time of interview. Next slide. Question?
Questions for? I have some. So thanks for that, and thanks for being a person who finds a way to get to yes. It's good to know we've got someone doing that in this challenging position. So it looks like this sort of focuses on recruitment, I think, and I'm just curious about sort of the intersection between your work and recruitment and the work of generally, I mean, we've been hearing about Perkins Hospital, but any of the facilities that you're recruiting for, the intersection of like addressing other challenges within the institution. So the morale generally, safety concerns, certainly physical plant we're learning about. It's kind of scary to think you're bringing people there to see if they want to work there when we have the boiler situation that we just discussed. But you know, work with, to the extent it's appropriate, working with the unions, like trying to understand what the reasons are that people would want these jobs or not, and addressing those issues as well as the recruitment that, and potentially that's about wages, potentially it's something else, working conditions. Can you talk about how those pieces are being addressed? So that's kind of one piece that I think relates both to retention, which we don't have data on, and I'm interested in that as well, and also recruitment, because people can talk to folks and see if it's a good job or not, right?
So one of my strategic initiatives for this fiscal year is to start tracking retention and using our data and the reports that we can pull from Workday. To answer the first part of your question, I do meet like monthly with Jenny Reese, for example, who's the AFSCME MDH Chief Steward. So we have a monthly check-in, like what's going on, what are some issues you're having, and let's try and resolve in those low-hanging fruit, for example. So I also host every 3 weeks a call with all of the HR at every facility and local health department, just to kind of give them updates, consistent, good information, and then I can also hear what's going on within the facilities and health departments and help address those challenges that they're having on the ground. So kind of just bridging that like disconnect and having more communication within our facility and local health department HR, building the rapport with the union and just the employees themselves. And just having transparent communication, I think, has helped significantly. We are definitely trying to have a proactive approach. So, you know, we're communicating as soon as we become aware of things. I've gotten a lot of positive feedback about that. And then just like assisting our employees and managers from that proactive approach of, you know, when you have a position, working with our outreach. We have created an outreach team within our recruitment and even have like a headhunter now that, you know, is not something common that we typically had in the state HR. So just utilizing those resources and building those relationships, I think, has helped.
And I will say more broadly, to pick up on something that you said, Delegate Charkoudian, that people also talk with each other, right? And how are we making sure that we are supporting our current employees and making them feel heard and valued? Because then that becomes a virtuous cycle, not just for retention, but also for recruitment. So in fact, I think one of, as Melissa mentioned, bringing in people who are doing more of that proactive recruiting. We've also started at the department level things like Mornings with Mina, where staff can come and join me for some tea and coffee and just chatting about life. And we had a coffee with donuts recently, Tuesday, in the lobby of our building. And actually, one of said recruiters came up to me, introduced herself, and said, "I'm really excited to come here because I think this is the direction that our department needs to go to show that, like, we're all in this together and there is a mission that we want to be a part of." And so I think doing things like that, my hope is, like, we're doing quarterly town halls for all the staff across the department so people can see that they're part of something, right? And my hope is that that also, at a higher level, fosters the culture change that then Dr. Jones is working at on that more granular level. So again, it's like not just words, but it's actually demonstrating how we're all coming together.
Yeah, and I would like to add that, Dr. Jones, for example, at the facility CEO monthly meeting was able to highlight some of the successes that she's put in place at Perkins, and it was well received with all of the CEOs at the other facilities. So just highlighting and sharing the successes and what's working and trying to implement that out across the department, which is, a big agency, but just trying to stay connected with everyone.
If I may, I'd like to add that that's been one of my priorities as I've gotten oriented to the system and gotten familiar with and gone on site to all of the 11 facilities. And every one of them has some form of an employee engagement initiative. So I'm looking at that and sort of trying to understand how they measure the effectiveness of those. But each one of them has something in place that is specifically oriented, like the committee that Dr. Jones demonstrated. Each one of them has something going on.
Thank you. Senator Hester.
I should probably know the answer to this, but are the patients, are they eligible for Medicare?
Some of them.
And are you guys like on top of what's going on with HR1? Like, I mean, it just seems like that could be at the federal level. If we have patients that are losing Medicare, what happens?
So I can speak. So I think for Medicaid, we are absolutely tracking HR1, and our goal with implementation will be, how do we make sure that people who are eligible to be on Medicaid stay on Medicaid? One thing to note is that the majority of the provisions from HR1 are for our expansion population. And I don't have the stats in front of me, but the majority of our patients in our facilities are not in that adult expansion population. However, I always view where there's an opportunity, let a crisis become an opportunity, and where this enables us to overall improve our outreach, improve our eligibility and enrollment processes. That is something that we're working very closely on with our DO-IT, Department of IT. As you know, we rolled out the Maryland Benefits One application. That is a platform that I'm hoping to leverage for all of this work, because we don't need to have people going by bus to multiple different offices trying to get childcare, trying to get time off from jobs so that they can get the benefits that they're entitled to. So that is very much the mindset in which we're approaching the HR1 work that I think also underlies, will help with overall improvements as well.
That's great to hear. Thank you very much. And then for Ms. Easley, I was really thinking about if there's anything that we can do to help you with your recruiting efforts, particularly on like the clinical staff, the social workers. Is there anything that the General Assembly can do to aid in those efforts?
I mean, I think, not off the top of my head, I can't think of anything right now. I think just to the salary piece, the differential for those clinical positions, but I am interested in, now that we're tracking, like, to see the success that comes from our outreach, from our headhunter and really trying to get that passive talent that may not be looking. And we've had some great success. I know some of the doctors, one that even went to Perkins was hired through that person. So I think once we have the data, then we can reach out if we need additional support.
And I think with that data, I mean, you all are in your communities, right? You are in your districts, that I think there is a really good opportunity to partner there where, you know, if there are messages to get out, or here's where you can go for more information, or this is where we're seeing, do you want an opportunity to serve in your state? I absolutely think that there are opportunities for you all to help us in getting the word out, whatever you're hearing on the ground, where there might be barriers, feeding that back to us, and we can share with you, you know, where we are seeing, okay, here's where we're trying to improve things. Let's brainstorm together about how we can best get there.
Well, thank you for the presentations. Did you have a question? Go ahead.
Thank you. I just, Madam Secretary, I just wanted to say thank you for the work that you're doing and the team that you've put together. There are a lot of balls in the air, I know, and there was a lot going on when you came in, and you've worked diligently to try to make corrections where they're needed and improvements. And so I just wanted to let you know that I think we're all very grateful for the work that you're doing. We know that there's a lot more to do, and we'll probably be asking you more hard questions as the time goes on. But I don't want you to think that that your work has not gone unnoticed based on what you have provided. So I just wanted to say thank you.
Well, I appreciate the opportunity to work with all of you. I will say that, especially in challenging times, I think it's on all of us as public servants and as leaders that we seek out the conversations, right? That we figure out how we move forward together. And I'll be the first to say that I ordered my magic wand, my crystal ball, and my superhero cape, and they have not yet arrived at my house, but we'll continue to do, you know, the best that we can.
Thank you. So, yeah, thank you all for coming and for putting together presentations. And I think quick shout out to our staff, Shane and Taylor. They will be in touch about some of the follow-up questions that we have. And I think we see you again in December. We've got a couple of other people who are coming, so I don't think we do. But hopefully we can get some of the data that's been requested, you know, just by email that we can distribute to the committee sometime in the next few weeks. And then we look forward to continuing to work with you on figuring out what budgetary or statutory changes are needed to really implement the vision that you have. And with that, I'm going to turn it over to Chair Hester for the second half of our meeting.
Thank you. And I think it's the
Final third.
The final third, because we have a hard stop at 11, right?
Oh, we don't have a hard stop, but we technically are scheduled for 11.
Okay, fabulous. Well, this is the Joint Committee on Fair Practices and State Personnel Oversight, and so we always like to give a chance to the actual personnel and the voices that speak for the personnel to come up. And so we'd like to thank you for being here and invite the representatives from AFSCME to come to the table. We're going to hear from both Jenny Reese, the MDH Unit Vice President of AFSCME 3, and Denise Gilmore, the Legislative and Political Director, AFSCME 3. And for those not familiar with the acronym, that stands for the American Federation of State, County, and Municipal Employees.
Thank you. Good morning, Joint Committee. Thank you so much for holding this briefing. My name is Denise Gilmore. I'm the Legislative and Political Director for AFSCME Maryland Council 3, joined here with our MDH Unit Vice President, Jenny Reese. We welcome the new MDH leadership, as well as the new leadership at Clifton T. Perkins. Can't emphasize enough the importance of stable leadership. We are excited to work with them. I want to start with talking about Perkins, and then I'll hand it over to Unit VP Reese to give a general overview, but I'll be brief. We spent last week catching up with our members at Perkins, and, I think the general feel was, good news. I mean, I think there is a sense that things are heading, in the right direction. Don't get me wrong, it is still obviously a challenging place to work. They did want us to highlight, some, major issues that, are continuing to, plague the facility and kind of keep things from, optimum operation there. I'll start with a few, issues that were highlighted out of our folks that work in admissions. There was an emphasis on, patient assaults and staff on patient assaults. One thing for consideration, I think it's probably a little bit out of the purview of this committee, but in 2015, we worked with the legislator to improve the time to panel patients this came out of an idea that we had with our health safety management team, but the process to get medication for patients. One thought that came out of our team last week was, patients arrive via court order facing serious criminal allegations. They're not required to take medications via that same court order. These patients, are at that point when they are coming in on admissions, sometimes, pose a serious threat to staff, other patients. They can assault other patients before they are able to take medication. One thought for consideration, we'd like to have further discussions on this with the department too. But working with the legislator to see if they can, with that same court order, be required to take medication. It would be a way to at least start treatment sooner for those patients to hopefully get them well. That is an idea for reducing assaults, at least immediately on staff. There's still frustration with patient flow. Obviously, our members are continuing to be advocates for more bed space. As you heard, there are about 1,000 beds across the system. Perkins is pretty close to capacity. All of our state hospitals are at capacity. We're continuing to call for more bed space. I heard a lot from our social workers last week. Obviously, if we don't have enough social workers, that makes discharge planning very difficult. But there simply just aren't enough beds in the system. If you add that with short staffing, it just makes for a very stressful environment. Patients aren't getting the services they need. We're continuing to just call for more bed capacity across the system. I'll remind the General Assembly again, we were happy to work with this body in 2021 to establish minimum staffing ratios for security and patients. Since 2021, we continue to struggle to meet those minimum staffing requirements. So that is something we want to continue to keep on the radar. And before I hand it over to Jenny, I think Senator Hester, you asked one of my favorite questions that I've probably heard all year related to boiler inspections. It's not a exciting topic, but the inconvenient truth is that we probably rely too heavily on contractors. I think we heard it in OHCQ, in the OHCQ presentation a little bit. The DLS analysis pointed it out last year. In relation to the use of nursing surveyors, the price of nursing surveyors to, merit staff there and how we spend more. We commend the department for, adding more pins and converting contractuals, that is going to be a long-term, wise decision to make that process more cost efficient. But I think we just saw it with Perkins too. These emergency repairs that are coming up. I mean, if you want to know how we extend a boiler's life from 25 years to 60 years, well, it's AFSCME members, right? I mean, 10 years ago, we had, stationary engineers. We had, I was looking back at my staffing analysis. I was the rep at Perkins 10 years ago. We had stationary engineers. We had steam fitters that worked there. We had, full-time carpenters and plumbers. I mean, we had skilled trades. I mean, those are, folks who maintain the life of that boiler, stationary engineers who maintain the life of that boiler with regular, maintenance. That's how you maintain a boiler, past its life. And when we talk about efficiencies and how you keep a facility, in a hospital going, that's a lot more cost efficient than spending money on bringing in outside contractors every month, or when, a boiler, goes out of repair. So, I say all that to say that, the department is working really hard to recruit staff. One of the things that we would like to work on, in addition to their efforts is, in our skilled trades, look at bringing in apprenticeships. I mean, I think, that Unit A, today, Perkins unfortunately doesn't have, electricians. I think they've replaced a lot of those positions for kind of general, non-licensed, general maintenance positions. I think this is an opportunity we can work together to bring back career jobs that can hopefully, maintain the facility in the future for, the next project for 30 years instead of, bringing in a Roto-Rooter at $120,000. Let's actually get plumbers in, not to call out a specific business. I don't want to do that. But so I say all that to say that things are heading in the right direction. We can still keep working. Staffing's a big issue, but I'll hand it over to Jenny. Thank you for the oversight. I appreciate it.
Thank you. My name is Jenny Reese, and I serve as MDH Unit Vice President for AFSCME Maryland Council 3. I'm also a licensed practical nurse at Springfield Hospital Center in Carroll County, where I've worked for nearly 14 years. Thank you for the opportunity to provide a brief response today. AFSCME represents more than 7,000 employees across the Maryland Department of Health. Our members work in state hospitals, the Office of Healthcare Quality, local health departments, Medicare eligibility, chronic disease prevention, health occupation boards, and many other areas that deliver essential public health services throughout Maryland. As part of my union responsibilities, I serve on the Agency Labor Management Committee. We meet bi-monthly with the secretary and their team to raise concerns from our members and work collaboratively to resolve them. Our goal is to help MDH operate more effectively and deliver better services to our communities. We firmly believe that listening to frontline employees reveals the true issues. One of the most pressing concerns we've raised is dangerously low staffing levels in our 24/7 facilities, like Perkins, which you've heard about today. When staffing is inadequate, incidences such as patient-to-patient and patient-to-staff assaults, as well as elopements, increase significantly. I've worked directly on the units. I know firsthand what it is like when you need more staff to safely monitor patients who pose to be a danger to themselves or others, and that support simply isn't there. This leaves both staff and patients feeling unsafe and fearful. Currently, we're working with MDH leadership on a joint staffing analysis for our 11 24/7 facilities to determine appropriate staffing levels for safe and effective operations. We're hopeful that with this new leadership team, we can finally make progress. Too many vulnerable Marylanders are stuck on waiting lists for beds in Western Maryland and Eastern Shore, or are languishing in detention centers awaiting psychiatric care. While much of my focus today has been on staffing at 24/7 facilities, It is important to note that this is just one of the many critical areas in need of attention. Many public health infrastructure is vital, especially as we face challenges from the federal level. ASBE members remain committed to serving all Marylanders, and we're proud to do so. Thank you for your support and continued oversight.
Do members have any questions? Delegate Harrison?
Thank you, Ms. Gilmore. I guess you mentioned really about, I guess, skilled trades and bringing them back into the facilities, and that way there is, I guess, a better oversight of the physical plant. And have you had those conversations, I guess, with the Secretary's leadership, the leadership team, to ensure that we don't, we work towards not having 50-year-old boilers and the mold, and having to wait and call in a company and, get a contract going with them, however long that may take to get through the system, so that we can address these issues much more quickly. Where are you in those discussions?
I think in short, yes, multiple secretaries.
Yes, thank you for that question. We have started having those conversations, discussing different contracts that the MDH currently has for some of our facilities that could be services performed by our ASME members. We discussed those at our staffing meeting with the Secretary this year. We also have been having continued conversations at our local levels, as well as reviewing the job descriptions of our maintenance mechanics and having those difficult conversations on that we do not have as many skilled trades as we previously we did years in past, as Sister Gilmore had mentioned.
It just seems to me that if we had staff, much like we have DGS here for our physical plant here, it might, it may be of a benefit not only to the people that we serve, but to the people who are employed there, so that those issues can be handled in a much more timely manner. We don't worry about our employees and the people that we serve, inhaling mold and those other issues. So I guess it's not really so much a question at this point, but when you talked about that, it just kind of, it perked me up, I guess you could say, perked up my ears on that, because we've had so much discussion this morning on the challenges in our physical plant, along with, all of the other challenges. But I think that probably most people don't think about the challenges to the physical plant when we start hearing about, staffing shortages in general and some of the other complicated topics that we've discussed.
I really appreciate the discussion, Delegate, because I think, look, it has a really big impact on recruitment too, right? I think, certainly in speaking, in conversations I've had over the year with, newer staff too, I mean, they see, going to work in an, aging facility versus, a newer facility. I mean, these things have an impact, right? Or working in a facility that has electronic medical records or not electronic medical records, right? Like, these are all things that have an impact. And I think the investment that we can make in modern state facilities is worthwhile for personnel, certainly. So we appreciate the support.
Thank you.
I was going to follow up along the same line with the question you had about like apprenticeships. And so ideally, we'd want like the staff, the staff taking care of the boilers. They do last, 60 years, which is an amazing feat. But just to make sure they're in really good repair and they're not going to blow up. But then if there was to be an apprenticeship program, I mean, there's the governor's year of service. We do have apprenticeship programs. Is there anything, how do we connect those dots? Would there be something that would need to be put in place legislatively? Do we actually need a program to have, and to enable AFSCME members to have apprenticeships, or is that something you can do on your own?
I think it already exists. A lot of it already exists. In fact, there are grant programs for it that General Assembly has done a lot already. It starts with a conversation and willingness and a negotiation and bringing in the Department of Labor, and yeah, a lot of it already exists.
Are there other questions?
I just wanted to follow up on some of the conversations earlier about the staffing trends that we were looking at, specifically at Perkins. And there was the conversation about the pay differential, and I'm just curious about your thoughts on that, or other thoughts that you have about, how to address the vacancy issues.
Yeah, I don't know that I'm prepared to comment on the differential today, just because I haven't surveyed our membership on that yet. I will say it appears as though there's a vacancy issue at multiple facilities, so I don't know if vacancy rate alone is indicative that that particular solution. I mean, it seems to me like wage increases are probably needed everywhere, I think, we are certainly, one tactic we've used in some other agencies is we've partnered on like job fairs, and I'm sure that's something our members in MDH would welcome the opportunity to do as well. I think where we can put our like AFSCME faces at a job fair and show, we are, good spokespeople for the department. We're always willing to do that. I think this, with obviously the work that the administration's been doing to court federal employees, now's a great time. I know we lost, we lose psychologists to the federal government a lot of times. I'm curious if we can gain some of them back now, that, things are going in the opposite way. I mean, apprenticeship programs, again, not to beat a dead horse, but there are a lot of apprenticeship programs in healthcare settings that we can do using the training and certification backgrounds, using more incentives. I mean, I think about like licensing and certifications in healthcare, where the state can incentivize those opportunities. I mean, those oftentimes don't like cost a ton if you're willing to, for instance, help with continuing education and like, social work or something. Like that's a good incentive. Again, those are all things, we want to negotiate, but we're willing to have those conversations, and that can be a good incentive for coming to work for the department.
Thank you.
I just want to go back to the particular types of vacancies that, you feel are leading to the assaults. Yeah. Like which, I mean, is it all of them? If there was a focus area, what would the focus area be?
I mean, Jenny, feel free to jump in too.
I mean, we definitely need more clinical frontline staff, social workers, rehab. We do not have enough supportive services for our patients in our hospitals. They're currently receiving very little, maybe 2 hours of therapeutic activities a day. So that doesn't leave them with much else to do other than pass contraband and get into altercations with other patients. If we did have more rehab, social workers, it would also help our patients with their progression through their hospitalization to attain our ultimate goal, which is restoring them to the community. But without enough social workers to be part of those discharge plans, when they have such a large caseload, those hospitalizations are prolonged.
And are those are those within the hiring freeze, or are they not in the hiring freeze?
So our,
Be exempt. They should be exempt, and feel free, certainly department behind me, but they should be exempt.
however, our maintenance positions are not.
Okay. The reason I ask is just because when we passed the Federal Workers Protection Act, there was a direction to DBM as well as funding to support the hiring of former federal workers. I think there was like $2 million in the budget there. And I talked with Secretary Grady at the time about doing like cohort hiring. So instead of, the Secretary of Health having to do all this, by herself, or the Director of Perkins, but there would be support and outreach from DBM to help with that. So it might be worth a follow-up conversation there, because there was money in the budget allocated for that. And if they're not part of the hiring freeze, I don't see why I wouldn't try to make lemonade out of lemons.
Sure.
Other questions? Seeing no questions, I guess that brings this portion of the hearing to an end. And I'm just really want to thank both of you for your ongoing willingness to support our state employees. And it seems like there's a really good collaboration with the Department of Health. It sounds like the communication right now is decent. And so hopefully we're entering a new era. And to the extent that we all can be helpful in terms of making things happen on our side and in the budget, we stand ready to serve as well. Any closing comments, Delegate Cherkoutian?
None. Keep your eyes peeled for, what are our December dates? I know we're back together in December. Can you help me out here? December 16th. On the December 16th, we have two meetings. So we'll cover a number of additional issues, and all of that will get posted with sufficient advanced notice. And yeah, thank you all for being here.
Thank you all. The meeting is adjourned.